Hi, my name is Jim Meadows. Welcome the first of the videos that you'll be receiving during this certification course. This video concerns itself with critical reasoning. It's very much, and clinical reasoning. It's very much an introductory video, and we will be expanding on it and also making it practical as far as your patient is concerned over the coming weeks and months. Not many people use critical reasoning, certainly not as a routine. You're actually, with your schooling, I mean, at every level in your schooling, you're actually dissuaded from using it by being made to recite lists of things, lists of countries, what rocks they produce and so on in physical therapy, lists of signs and symptoms, and lists of treatment and so on. So the use of lists and labels and so on, clinical practice guidelines are a good example of this, basically prevents you from using critical reasoning, because there is no critical reasoning in this. It's pretty much all rote and regurgitation. We'll try not to do that with this. So critical reasoning we'll talk about as far as definition is concerned. Clinical reasoning is simply a subset of critical reasoning, as critical reasoning is applied to your patients, both in their diagnosis and treatment and other management. So if you go on the net, you'll find that there are dozens and dozens of definitions of critical reasoning, and just how useful these are is difficult to say. A lot of them simply aren't. We've got three up there, and they all make much the same thing. In short, critical reasoning is problem solving using rationality, logic, information, your knowledge, both systemic and contextual knowledge, and your ability to basically integrate all of these things, interpret the result, and then analyze everything and come up with a problem, with the solution to the problem. As I say, this is generally not done. If we look at the methods of it, taken from formal logic, which we're going to modify considerably actually, the methods include deduction, and deduction is almost never used in manual therapy or medicine, come to that. Deduction is when if the premises are correct, then the conclusion of the problem, the solution must be correct. And our problem is the premises are rarely 100% correct. So this isn't the best way of going about it. The exception to that would be when you come across a pathognomic sign, and this is where the sign definitively identifies the condition that's causing it. There's a number of these, not a whole lot when you compare the number of possible conditions in healthcare. They're very rare, and I would say in manual therapy they're pretty much non-existent, but the logic would go, sign A definitively identifies condition B. Patient C has sign A, therefore patient C has condition B. Never works. We just don't have those sort of luck. Inductive logic does exactly the opposite, actually. You'll see something, and then you'll try and make a pattern of it, and you're going from the small to the large. So you're making a diagnosis based on flimsy evidence. Now it's interesting because these two, inductive and deductive logic, are linked. Inductive reasoning is what generates a hypothesis. So you see it, you make an observation, then you see it repeatedly. You look for it repeatedly, and you come up with a hypothesis over why you're seeing that observation. And then you use deductive logic to prove that observation, or prove it as much as a scientific proof can be made. Pattern recognition is for experts. This is where the therapist, has seen the condition so many times he doesn't really even have to think about it. One or two signs and symptoms will tell him exactly what it is. Now, you've probably all somewhat experts in tennis elbow to one degree or another. And we'll talk about the other in a second. But you've read about this a lot. You've probably seen more than a couple. and it's a very common condition for you to be taught and for you to see. So the expert would look at this, go, lateral elbow pain, it's almost certainly tennis elbow because statistics say it's going to be. And then you say, okay, what bothers you? Gripping things. There you go. And then you palpate the tendon, that's tender, and there's your diagnosis. Pattern recognition is very, very rarely wrong in the correct hands. Very rarely wrong in an expert's hands. When it does go wrong, though, it goes badly wrong. If it goes wrong, then you've got the completely wrong diagnosis. The difference between an expert doing pattern recognition and maybe you doing pattern recognition is that the expert has seen many more outliers than you have. So they're going to pick up stuff that you're going to not pick up. So they will correctly identify the condition more often than you will, simply because of the outliers. Differential diagnosis is really not a separate method by itself, but it's used so much and it's so popular and the term's used so frequently that I thought we'd cover it. So basically this is where you're trying to decide which of two or more diagnoses is correct. Now if you remember House, the TV program, this is what he did all the time. They'd come up with a list of 5 or 6 diagnoses that fit the first couple of observations, and then basically prove each one or disprove each one. And generally speaking, in that show, he managed to almost kill the patient twice, just saved their lives at the end of it. Still not know what the diagnosis is at the end until suddenly he bumped into a wall and went, oh yes, I know what it is. And he's had a sudden epiphany, and there's your miracle diagnosis. It's a crappy way of doing medicine, basically. Hypothetical deduction is what's mostly used. The terminology is completely wrong. This is not hypothetical deduction because it's almost never 100% certain what your diagnosis ends up being. Really, the term should be hypothetical abduction. Now, abductive and inferential, the other name for it, inferential reasoning, is about best fit. So, in this case, if you look at a diagnosis, you would come up with a hypothesis based on a few clues, a few questions that you've asked the patients, and then you would ask more questions that would fit that hypothesis. And if your answers to those questions and tests, results of the tests you do, fit the hypothesis as the best fit, that's your diagnosis. The other way you can do it, which is what most people do, unfortunately, is ask almost random questions. And it's all over the place, and then you try and make the best fit from all of that information, and you run into real trouble with that because you've got way too much information for you to do anything with, and we're going to talk about this a lot. Clinical practice guidelines and treatment-based classification schemes are not clinical reasoning processes. They are lists of things you follow. Now, clinical practice guidelines can be useful, especially for the new therapist. The problem is if you keep on using them, you never, ever get to become a critical thinker when it comes to your patients. And the problem with clinical practice guidelines is they can't cover every eventuality. I think their biggest uses are in more serious conditions. And if you think about it, with the X-ray protocols where you're trying to decide whether to do an X-ray because there may be a fracture present, these are clinical practice guidelines essentially, but they're not about treatment in this case, they're about management. Do I need to take an X-ray or not? And they're not a bad way of doing it. There's a number of these, and the more serious the condition, I think probably the less experience you have, the more useful the clinical practice guideline is. For example, we will do some for VBI, vertebrobasilar ischemia, and these are the ones you really don't want to screw up. So all the time you're looking, it's a sensitivity thing. Could they have it? Could they have it? Could they have it? Yes, I think they may have it. Not they've got it, but they may have it. I need to get this out and let somebody else image this, do whatever it is they're going to do to prove or disprove the idea. Treatment-based classification schemes, on the other hand, are not like that at all. You make a list of their signs and symptoms. Essentially, you then go to another list, see if they fit together, and if they do, they slot into that little pigeonhole. And that's what you base the treatment on. No clinical reasoning whatsoever. And there's a number of problems with this. not least of which is the one we talked about with clinical practice guidelines. You never learn to critically reason. The real big problem with this, though, is that patients rarely fit into these little pigeonholes. So you're constantly folding and fanning and squeezing and deforming to get that information to fit that bloody hole. And essentially, if you get one standard deviation in that hole, people tend to be happy, forgetting that 1/3 of patients will not fit in there. So they either get mis-slotted or they're given up as being, I don't know what the hell it is, just do ultrasound. So these are the methods. We're going to be looking in detail at pattern recognition, which we can't teach you. This is about quality experience, reflective practice, understanding where you went wrong, where you went right, and learning from each failure. And failure is a big learning tool. The more you fail, the more you learn. And we'll be looking at hypothetical, abductive or inferential reasoning, and we're going to come up with a different way of doing this, which is using essential illness scripts, which we'll talk about, and then hypothetical script focus, abductive reasoning. So this is where we're going. We're going to try to install a pattern of critical reasoning, clinical reasoning, as we go through this program, and make you better therapists as far as diagnosing and managing the patient is concerned. So, hope you enjoyed it, and I'll see you on the next video. Bye.